Good afternoon. My name is Dr. Adam Murphy, and I'm representing Northwestern Medicine, and I'm also on faculty at Cook County Health and Jesse Brown VA. And I'm talking about genetics and prostate cancer disparities facing African Americans. I wanted to highlight that the incidence of prostate cancer is 78% higher in men of African ancestry or non-Hispanic Black men relative to whites. The mortality disparity is more stark with African Americans having a 230% higher mortality rate than whites, and that's persisted over the past 30 years of prostate cancer, including the PSA screening era. In 2017, the rate for non-Hispanic Black males was 36.8 per 100,000 compared to 17.8 this increased baseline incidence is associated with an increased presentation at regional and metastatic disease stage, which is responsible for about 76% of this mortality disparity. Many believe that further issues with access to care and quality of treatment received are responsible for much of the rest of the mortality disparity. Several studies have now shown that when Black men receive equivalent care in the setting of clinical trials or in the VA, that the mortality disparity disappears. As we described, Blacks have higher incidence. Twin studies from the Nordic region, like Finland and Norway and Sweden, suggest that the prostate cancer is 42 to 58% heritable, meaning that 42 to 58% of the incidence is also environmental. Black men with prostate cancer present with about 2 years earlier on average and have nearly 6 times the odds of presenting with prostate cancer before the age of 55 relative to whites, yet present with regional and metastatic disease more often. Given the disparity in incidence and the age of presentation that Black men face, we would expect that the genetic burden of prostate cancer risk loci would be higher in men of African ancestry, including West Africans and African Americans, and that these genetic loci would have a bigger impact on early prostate cancer. There's actually data from 2 recent studies. One is by LaChance et al., and one is by Dr. Conti et al., that explores the incidence and age effects. Inherited variants, in particular genes like BRCA1, BRCA2, and HOXB13, account for some cases of hereditary prostate cancer. Men with variants in these genes have a higher risk of developing prostate cancer, and in some cases, other cancers during their lifetimes. In addition, men with BRCA2 or HOXB13 gene variants may have a higher risk of developing life-threatening forms of prostate cancer. Data from Dr. Isaac Powell and from Dr. Ruth Etzioni using autopsy and SEER data suggests that the tumor progression rate is faster in Black men. That accounts for their higher mortality rate. There have been 2 recent studies evaluating known germline mutations in Black men and in Black women. In Black men, it focused on 1,000 metastatic prostate cancer patients, with 188 of them being Black and 669 of them being white. And in females that were diagnosed with breast cancer from the 4th study. There were 57,000 whites and 6,700 Blacks. The takeaway from these studies are that there were not higher risk of having established pathogenic cancer variants for Black women or for Black men. They were very similar to their white counterparts in both prostate cancer and in breast cancer. But there were a lot of variants of unknown significance for Black men and women, higher than that for white, showing that these patient populations are still under-investigated. It also shows that the most harmful mutations were shared by Black men and Black women and other racial groups, and those were ATM check 2, BRCA1, and BRCA2. There is remarkable similarity in the disparity in survival that are shared by all the ethnic minority groups. Although the 1, 5, and 10-year relative survivals are high for everyone, whites have higher survival rates compared to all the other ethnic groups, which are remarkably similar, pointing to the fact that most of the survival disparity is probably from social determinants of health. Blacks do have 2.3 times the mortality rate of whites, and this is exaggerated in Black men under age under age 50 to be 4 times the mortality rate of whites. Until recently, guidelines were recommending that all men begin screening at age 55 without firm recommendations for Black men. I honestly believe that this policy contributed to delayed detection for Black men, and we may see a reduction in the mortality disparity over time because we may be screening at earlier times, especially for young prostate cancer patients when it's more lethal. Clearly, level 1 evidence is lacking, but Dr. Nyame from UW recently modeled the age ranges for PSA screening that would achieve similar mortality reduction and limit over-detection as it does in whites from age 55 to 69. They found that the screening recommendation for Black men that would have the similar benefit would be age 45 to 69. So I believe that the focus of the disparity investigation for prostate cancer should be focused on incidence / early age of diagnosis, and that delayed diagnosis is mostly an issue of social determinants of health, and policies and research funding should try and attack that issue. The 22 established SNPs that are associated with aggressive disease are not more elevated in Black men relative to whites, suggesting that the focus should be on incidence. There are 4 autopsy studies that have been done in Nigeria, which is the most common ancestral population for men of West African ancestry in America or African Americans. These 4 studies go against the conventional wisdom that the excess risk of prostate cancer is from their West African ancestry. We got to lead one because we believe that prior autopsy studies from the West African region were less than ideal because they would oftentimes have longer time for people to be deceased to be included. They didn't necessarily have the same level of step sectioning to review at 5-millimeter intervals. And we wanted to make sure that there was pathology consensus between the Nigerian and the American pathologists to make sure that we were grading similarly. We did this, and this was published in the Prostate in 2021. We got representation from the major tribes in Nigeria, and they were mostly recruited from Lagos and Calabar. Overall, we came up with only 3 prostate cancers out of this 34 patients, which gave us a crude 1-year prevalence of latent or undiagnosed prostate cancer of 8.8%. This is actually really similar to the other 3 studies' crude prevalence rates, which were between 6.4 and 11.6%. And these autopsy studies go back to 1980. Even though our sample size was small, the remarkable consistency in prostate cancer prevalence across these studies indicates that prostate cancer may not be as common in Nigeria as solved on the basis of cancer registry data, though the frequencies of risk SNPs are similar between West African men and African Americans. This is from a meta-analysis of 19 autopsy studies from the United States and Europe. And so for this, the Black represents US and whites and European men, white Europeans. The gray are U.S. blacks, and the white or lighter gray bars are East Asians. And this is talking about the rate of prostate cancer on autopsy across race, with over 6,000 men involved. What we find is that the rates of latent prostate cancer in American and UK whites is about 30%, and it's about 48% for blacks. This is actually consistent with Ike Powell's data, which showed a 64% crude prevalence in blacks and a 48% prevalence in whites, and those are really well done study, published in the Journal of Urology in 2010. That means that Americans have 4 to 6 times higher rate of latent prostate cancer than West Africans and Nigerians in particular, meaning that there's an American disparity in prostate cancer that is just worse in blacks. But to figure out what the risk SNPs are, people from the multiple consortiums that Chris Hayman has put together have done a large multi-ancestry GWAS and then did a meta-analysis. And they were able to identify 86 new risk SNPs associated with prostate cancer risk. And of course, there are novel candidate genes now that they've found that they think are associated with prostate cancer development. This is on top of the 183 previously known risk SNPs. So they use the total, which are 269 risk variants, to come up with a genetic risk score. And then they use that risk score to see what the predicted risk of prostate cancer was in men of European, African, East Asian, and Hispanic ancestry. And then they performed 2 independent replications in European ancestry and African ancestry men to validate its accuracy. Looking at the lowest decile of risk from this genetic risk score compared to average risk, which is 40 to 60%, people in the lowest risk very similarly had lower odds of prostate cancer diagnosis. And when you look at the top 1 percentile of predicted risk from the genetic risk score, it meant that relative to average risk, they had European ancestry men had almost 12 times the odds of prostate cancer. There was only about 5.7 times the odds in blacks. So there may be more risk SNPs to discover in blacks at new loci, or maybe that the loci that there have been found need to be searched in the same region for a better predictive risk SNP for African ancestry men. But overall, the genetic risk score works. If you limit the SNPs to those who have an odds ratio greater than 1.1 for increased risk of prostate cancer diagnosis, we found that blacks had a slightly higher frequency of these higher risk SNPs, higher than all the other racial ethnic groups. When they look at the genetic risk score SNPs to see if they're associated with low risk or high risk prostate cancer, they were equally associated with both, meaning that the genetic risk score cannot predict aggressive disease. Again, focusing it back on incidence of prostate cancer as a disparity. They did stratify their SNPs by age to see which SNPs are most associated with increased risk by age strata. And most of the risk SNPs that they identified were in men who are younger than 55. There were a few that were in that older than 55 age range, and almost all of them are associated with increased risk of prostate cancer, not decreased. So my conclusions are that based on the genetic risk score developed by Conti et al. on the backs of or shoulders of other prior work, blacks do have a higher distribution of higher risk SNPs compared to other ethnic groups, which may explain their increased incidence. And because these risk SNPs are mostly associated with early prostate cancer before age 55, it could explain their higher likelihood of having prostate cancer before age 65, and also the earlier age on average, which is about 2 years. I think we need more GWAS studies and linking studies in African ancestry populations to further improve the genetic risk score and to provide estimates of absolute risk and to identify more causal alleles to uncover the underpinnings of prostate cancer. Then I do think that focus should be on the genetic predictors of rapid tumor progression and lethality in Black patients. These are my references. Thank you for your time.